Hello, this is John Neary, and I'm doing a 5-minute video for Edinburgh renal students, which should help you out when you're doing your attachment in the renal ward. Today we're going to cover a differential diagnosis of acute kidney injury. This is important because when you go on ward rounds, you may see patients with multiple problems and they've got acute kidney injury, and it can be difficult to tell exactly what has caused their kidney injury. The case illustrated here is an example of this. So an elderly gentleman with a past history of diabetes and chronic kidney disease comes to A&E shocked. He's got a ruptured abdominal aortic aneurysm, which is repaired in an emergency fashion, and he's given some flucoxone and amoxil as cover. Despite this, he becomes septic post-op, and he's given some gentamicin. He requires some further imaging, and after all of this, unsurprisingly, he becomes oliguric with acute kidney injury, and his creatinine rises to 660. You can pause at this stage and think what potential causes here, or we can just go through the causes as you might expect. I expect most students would be able to break down acute renal failure into pre-renal, renal, and post-renal. If you want to pause for a minute and think of the pre-renal causes before you go on. So the pre-renal causes are most often due to, or always due to, hypovolemia or hypotension. Hypovolemia can be due to GI loss, and this is most commonly due to diarrhea or vomiting, but it can be due to other causes such as hemorrhage, fluid loss from burn victims, or third spacing. Any cause of hypertension can cause pre-renal failure, so I put low cardiac output here, but it could be due to taking excessive antihypertensive medications as well. The next thing is post-renal, and again, if you want to pause for a minute while you think of post-renal causes, I tend to say to students, if you think of the 4 C's and the 2 P's, so the 4 C's are clot, calculus, and cancer and compression. The first 3 are generally within the urinary tract. Compression can happen from out with the urinary tract, whether that's due to a malignancy outside or a fibrotic process altering the flow of the ureters. Any man over the age of 50, you need to consider prostatic enlargement, and in any elderly woman, you need to consider uterine prolapse as a rare but recognized cause of acute kidney injury. Finally, when it comes to renal causes, this is an area where a lot of students have problems. So again, if you want to pause for a minute and think, while I'm teaching students, what I tend to say is, if you imagine a molecule floating from the aorta through the kidney, what are the structures that it passes through, and you should be able to link up a cause of renal failure with each structure. So first it goes through the renal artery, and if you've got renal artery stenosis, you can develop renal impairment. This generally requires a second hit, such as dehydration or starting an ACE inhibitor. The arterioles are affected in HUS-TTP, and you can get onion skin lesions in the arterioles and glomerular thrombi. Moving on to the glomerulus, then this can be affected by rapidly progressive glomerulonephritis. Some people point out this isn't exactly acute kidney injury, but in fact it's often difficult to set a clear timeline for when the acute kidney injury happened, and sometimes patients who at first appear to have acute kidney injury actually turn out to have an ORPGN. The 2 big ones, however, are acute tubular necrosis and acute interstitial nephritis. Acute tubular necrosis may be ischemic, which is generally due to any cause of prolonged pre-renal impairment, or it can be toxic, and the toxins can be exogenous, which tend to be drugs, most commonly in this day and age contrast and gentamicin, or it can be endogenous toxins, things like myoglobin causing acute kidney injury and rhabdomyolysis. Interstitial nephritis is most commonly due to drugs, and the drugs we commonly see are penicillins, proton pump inhibitors, or non-steroidals. But in fact, any drug can cause this, the same way as any drug can cause a rash. And you can also get interstitial nephritis in the setting of infection, be that bacterial infection, pyelonephritis, or CMV infection, and finding some infiltration. So hopefully this has been somewhat helpful. If you consider the original case we saw of the gentleman, the elderly gentleman with diabetes and ruptured AAA. The slides that are appearing about now should give you a number of potential causes of kidney impairment in this gentleman. So hopefully this has been helpful, and apologies, the slide didn't seem to appear, so I've added it on now. Here's the case that we showed earlier. You should be able to think of 7 potential causes of kidney failure in this gentleman, and I will leave you with the answers on the last slide.